That was really great. Thank you, Lynn. I'm going to introduce myself. Hi, I'm me. Before I get started, I'm going to talk today about the Minima stent, but I really want to give a shout out. I watched as people came in. There are seats up here. I know nobody likes to sit in the front. It's like fourth grade, but if you want, there are seats. I want to give a big shout out. We talked about the partnership that we have with the FDA and now also through their efforts, the PMDA over in Japan, which is phenomenal. But the other big shout out should go, and I see a lot of folks here from them, these companies. We put something out online, and what are the biggest obstacles to getting new devices in our space? And a lot of that has to do with cost of researching and development and regulatory, and maybe we'll talk about that in the discussion. But the people who are in this room who helped develop these products, they're doing this and they're taking a huge risk. Companies like Starlight, like Renata, like Tim's company, et cetera, these guys could be doing something else and they're not. They're investing in this space, and I think that deserves a big hand by everybody in the room. All right. Enough of that touchy-feely stuff. So here's my disclosure. I am the Chief Medical Officer for Renata. That's the company I'm going to be talking about their product. So I'm going to take this like I usually do, a little historical because I'm old, and this puts things in perspective for me. So I was around for this. In 1991, Chuck Mullins published this paper. It was the first paper of stents in congenital heart disease, pretty early in the game because Julio Palmas first put his stent in, which is what we used, in 1987-88. So Chuck was all over that with Dr. Palmas together. And Chuck, because he was and is a genius, said to us all, in no uncertain terms, me in particular on a podium at the AHA, don't put these in patients unless they can become adult size. You are literally, deeming them to having surgery for their stenoses. And Chuck, I can tell you, those who know Chuck, felt pretty strongly about that, and he let you know that. But then there were people like the guy who trained me, Lee Benson, who's been here all week but left to do live cases today, and didn't take Lee very long to say, well, wait, I could figure out a way to put these in babies. And this was during my fellowship, and we were cutting Palmas shot stents in half where they connected and finding ways to get them in tiny infants and showing that it worked, although if you read this paper, it's actually terrifying. Because we had some very challenging outcomes. Lee is a brilliant technician, but even he couldn't overcome some of the equipment challenges that we had during that time. And Lee recognized this, and in this paper, he says repeat stent dilations adjusted to vessel growth will be necessary, and this limits the usefulness of smaller implants that are possible in infants. And I think those of us who do these implants, we have all been living with that for the last 30 years, for sure. We took a crack at this when I was in Miami. A young man named Rob Stanfill went on and wrote this up for us, and we, along with our surgeons, believed there was a place for putting stents in small babies. A lot of these cases were emergent. The surgeons felt it was better to treat them in the cath lab. I know this sounds commonplace now, but it wasn't in the early 90s, and we were treating kids on ECMO and kids who couldn't get out of the OR and in the unit, and having pretty good results. And what this graph sort of showed everybody, let me see if I can get this bad boy to work. You guys promised me if I keep, oh, there you go. Oh, boy, that's going to take a while. Okay, so what this graph shows is you could take a small stenosis, you could make it bigger, then the kids come back at some indeterminate time, different for each patient. There's some intimal growth. The stent diameters actually get a little smaller, but then you can redilate it. And we thought this was a great advance. And in fact, I think I witnessed a whole bunch of babies being saved by this. But I can tell you, pretty much everybody in this study has subsequently had surgery to address those fixed stenoses that Chuck was telling us about, because it was inevitable because they were little when we put them in. So here we are, 2022. And I think the holy grail, sorry, I'm a little partial to these guys, in our field is finding a stent that can last for a lifetime. I think PediaStent's idea is genius. I think all the people out there trying to figure out this problem, hats off to them, because we have to do better than we're doing now. Because I can tell you, despite all of our efforts in this room, we're 2022 and there is no stent specifically designed for infants. Okay? There is no currently approved stent for use for infants. And there's no suitable, in my opinion, long-term stent strategy for putting in infant stents as we speak. And that feels bad because guys like Chuck and Lee were talking about this over 30 years ago, and we have yet to figure this out. And I think it's high time we do. So here's our current practice, right? We put in stents and we can unzip them, a term I'm not too happy with because it sounds very nice and controlled, and we all know it's not. It's like throwing a grenade inside a child's vessel and hoping that the pieces land in the right places. But that's what we do, and I do it too because that's the best we got. We can send the kids to surgery. Surgeons can split stents. If you're Mark Galanowitz, I just saw Mark, and you have the talent and the patience, you can actually take that out of a vessel, although most surgeons I know have neither and don't do that. They longitudinally split them. You're lucky if you live in Columbus. We have bioabsorbable stents that are coming online. Dan just gave us a fantastic talk about that. We have purposely breakable stents. The Occipitous stent is the one that comes to mind. There's another company in Germany looking at these stents that purposely fracture. And this may be great. And as Dan was showing us, as the PDS stent sort of absorbs and dissolves, the vessel begins to beat, and that can potentially lead to unassisted growth of that vessel. And if that happens, I'm all in, and that's what I'm going to be putting in babies. I think there's a question, I just don't know if that's going to happen with stenotic vessels. I just don't think that answer is known. And the one commonality of all of these solutions, both the current ones and the potential ones, is they result in the loss of stent integrity, which may be okay, like in the bioabsorbable case, but maybe it's not okay. There are a couple of papers, shout out to Hawaii, I know she's here somewhere, who I thought her group wrote a great paper. But one of the things, and what this paper basically says is if you pre-stent before you unzip, you get a better result. And that's how we do it, based a lot on the beautiful work that they did. But they also sort of pointed out that by adding another stent, the vessel, they had created stenosis, may be better off for it. And that just makes me wonder if stenotic vessels are going to be okay without a support system over the course of the lifetime. I hope they are, but I don't know that they will. There's this old paper by Mark Law and the guys in Texas who wrote that when surgeons go in and try and take away the radial support that a stent offers, not only does that not help, it actually hurts and may make that vessel more prone to needing intervention. And in the back of my mind, this just makes me wonder if kids who have coarctation and pulmonary artery stenosis, are they going to just need stent support over the course of the lifetime? And I don't pretend to have the answer, and I'm excited that one day we're going to find that out. But the point is, that's what this company was built on. The guys at Renata believe that we need a stent that's designed to maintain structural integrity and vessel wall support over the course of a lifetime. And if that's true, this is the product that they've developed. So this is a stent that has an implantation range as small as 4 millimeters and can be dilated to 22 millimeters. The idea is to maintain the same radial strength, and it does on benchtop testing over the entire expansion range. It's made of things we know, cobalt chromium, and a lot of the stents we used. Has a closed cell design. The radial strength compares quite favorably to other stents that we use, and as you can see here, there is considerable foreshortening when you get to the larger diameters, and I think that's important at the smaller diameters when it really counts, in my words. So on the x-axis, for instance, you have stent outer diameter, 10, 12, 14. We're not seeing a lot of foreshortening. When you get to the adult diameters, right, 18, 20, 22, we see a lot of foreshortening like you saw in that picture. And if they don't need vessel support, we're in good shape. If they do, that would mean another stent for those patients. I really like what they've done with the delivery system. This is a specifically designed delivery system with infants in mind. So it's equivalent to the OD of a 4 French sheath. It comes self-packaged. You don't have to crimp anything. That'll be nice for a change. It's a covered system, so you can pass it through the tricuspid valve quite easily. Goes over an 018 or 014 wire, and it has a solid port for angiography. This is a little hard to see, but it's actually the balloon on the stent that acts, the stent is covered, the balloon tip acts as sort of the dilator, if you will, so you don't need a long sheath to put this in. And then once you deploy the stent and take out the catheter, there's a side port, and you can use that same sheath for your follow-up angiography. Pretty slick. So a lot of what I'm going to say in the next few slides, or some of it at least, is covered in this article. If anybody's interested, we published it last year in 2021. It was the animal work that we did and discussed with the FDA to get to our GLP studies. So here's a few things we've learned, and then I'll just finish off with that. Cobalt chromium, it's a time-tested stent material. It has a predictably biocompatible vascular profile and a predictable healing response. This is demonstrated in this particular piglet that was implanted as a neonate, about 4 kilos, and then had 2 redilations to get this towards an adult size. And without going into the details, you can see by the histology it basically has a typical response for a cobalt chromium stent that's been implanted and dilated, so nothing too shocking there in terms of inflammatory response. We learned in the animal model that it's pretty trackable. Those of you who've done piglet work know that they're not a very forgiving breed, and it's a hard course to the pulmonary arteries. This is tracking that system over an 014 wire into a left pulmonary artery, which can be a difficult place to get in a piglet. And lo and behold, we just found out that that's true in kids. So this is part of the EFS trial that Darren Berman's going to talk about later. This is a Renata stent in a little kid going across a side cell of another stent that's been put in there. That can be a tricky course over an 018 or 014 wire, and you can see that that turns out pretty well in terms of tracking. So that's good news for the stent. We learned that it implants predictably over and over in the animal model and in our EFS study, which Darren will talk about. You can see this is an LPA stenosis after a Glenn, courtesy of Shabana, that has been treated with a Renata stent, and it blows up, not surprisingly, like all the other stents we've always put in. You can put it where you want it. She tends to blow her stents up a little faster than I do, but you can't argue with the results. This is another little baby. You can do the same thing in the aorta. This is Darren. This is actually the first case, which I think he'll be showing in great detail during his talk. This is a recurrent stenosis after a complex arch repair and an angioplasty attempt. Was left with this. You can see when Darren puts this stent bone up, nice and slow. Goes exactly where he wants. Balloon deflates. There's really nothing new and shocking here, but we have to prove all these things to make sure it's not worse than what we currently have. Sorry, that's a repeat. Oh, wait, it wasn't. It was a fooler by me. Can I go back? Okay, I got it. I thought I wanted to point out that the improvement in vessel diameter that we've seen so far, and this goes for the animals and the kids, is pretty predictable. I won't play that, but it looks like other stents when you treat a stenosis either in the aorta or in the left pulmonary artery. So again, nothing shocking. You've all seen stents and angiograms, but when you have a new product, you need to reprove that these things will act like they're supposed to. And in this case, so far, so good. This is going back to the animals now, because the one thing, of course, we can't prove to the FDA or ourselves or you guys is redilation, or otherwise we're waiting 20 years for these babies to grow up, and I'll be retired, and all of you will be old, and we'll never have gotten the answer. So we did do that in the animals. As Dan said, piglets grow really fast. This is a piglet at 2 months. This stent was put in when he was 3 or 4 kilos. Now he's 40 kilos. Can't really see it well there, but we blow these up in 2 millimeter increments. So it measured 5.8. We blew it up with an 8 balloon, a 10 balloon, and then that stent measures 10. Okay, a formula stent can do that. So we really haven't gotten anywhere. But then we continue to let these animals grow. Okay, this is now at 5.5 months. Now he's well over 200 pounds, a little bigger than we wanted, but COVID got in the way. We blew that up with a 12 millimeter balloon, a 14 millimeter balloon, a 16 millimeter balloon, and I'm sorry, all we had was DSA, but again, the stent measures close to 16 millimeters. We would have loved to make this 22, but as Dan pointed out, even though the pigs are gigantic, their vessels are not, so without exploding the pulmonary artery, we left it like this. I will point out that there's a side branch that the stent crosses, and even though it's a closed cell stent, we consistently in the animal model saw side branches stay patent, which is good news for any stent we put in. This is sort of what that growth curve, assisted growth curve, looked like as we redilated that stent. There's lots more data. Darren, I don't know if you're in the room, but Darren Berman is the national PI for a multi-center EFS that just completed, and with the assistance and partnership of the FDA, we're getting ready to roll into a multi-center pivotal in the United States, and it would be great to think that after Darren shows his EFS data this year, that maybe next year we can come back and show you the pivotal data for this exciting product. So I'll conclude by saying currently, in my opinion, we have suboptimal solutions for stent therapy in babies and infants. It's just not good enough. I think there are a variety of really exciting solutions coming up the pipeline, and I'm super keen to see where they all end up. And we really eagerly await the ongoing clinical trials, and thanks for your attention.